Good afternoon, everyone. The summary of my talk is don't forget about alcohol. I put this slide in to remind you that, yes, we have an opioid crisis, as was amply illustrated by Dr. Volkoff, but we always have an alcohol crisis. And when you look at the number of individuals in the United States with an alcohol use disorder, it's 14 million. When you look at the number of individuals with an opiate use disorder, it's 2 million. So I just want to emphasize, I think it was best said by Paul Summergard at an APA meeting, American Psychiatric Association meeting, I think it was 5 years ago, where he said, if you've never seen an alcoholic in your practice, you're delusional. And to pick up where Nora left off, basically, I want to make the case that alcohol is a major contributor, as with opiates and all drugs of abuse, to what we call the deaths of despair. And there has been a recent publication, very recent, by Wolf et al., where the deaths of despair that were originally described by Angus Deaton and Ann Case have now been argued to play a role in a wider range of individuals. They continue to contribute to the decreasing life expectancy in the United States. Now it's ages 25 to 64. And alcohol plays a prominent role in these deaths of despair, contributing to 20% of all drug overdoses. And I want to remind you that if you take alcohol with opiates, 2 + 2 = 5. If you take alcohol with benzodiazepines, 2 + 2 = 5 when it comes to overdoses. 26% of all suicides, alcohol is involved, and half of liver disease in this country is caused by alcohol. And since 2015, these patterns of increased mortality are now observed across many racial ethnic groups, not just white Anglo-Saxons between the ages of 45 and 54. I want to remind you that a lot of what we do is not new, all right? I just finished Chernow's book on U.S. Grant, the president. It's a tome. It's about this big. It took me 2 years to read the whole thing. But there's a beautiful quote in there from Mark Twain in a letter that he sent to Henry Ward Beecher. Mark Twain published the memoirs of U.S. Grant. It was a huge bestseller. But Grant never addressed the issue that he struggled with his whole life, which was alcohol use disorder. And he basically licked the problem somewhere around the Battle of Chickamauga, as I recall from reading the book, because throughout the war and his presidency, he basically stayed sober. And Twain wrote the following: I could understand that feeling. He had set out to conquer not the habit, but the inclination, the desire. He had gone at the root, not the trunk. It's the perfect way, and the only way. I speak from experience. How I do hate those enemies of the human race who go around enslaving God's free people with pledges to quit drinking instead of to quit wanting to drink. Mark Twain. He, by the way, also said it's easy to quit smoking. I've done it 20 times. So in this realm, one of the things we've been doing at the Alcohol Institute, and this has been in collaboration with Nora Volkoff and her laboratory, which is also in the Alcohol Institute, and in my laboratory, which is at NIDA, but we came up with a construct that really came out of NIMH's research domain criterion, which is an addictions neuroclinical assessment, a framework of precision medicine through individualized diagnosis, prevention, and treatment. And we took the 3-stage cycle and we hypothesized that in the domains of incentive salience, negative emotionality, and executive function, one could, with scales and neuropsychological tests and neuroimaging, pick up other, if you will, endophenotypes that could be useful ultimately for diagnosis, but also ultimately for individualized treatment. And I just wanted to remind you of a paper that Laura Kwakow just published with all of us, Nora and I, Carlos Blanco, David Goldman, Nancy Granados, and others, in the American Journal of Psychiatry, where we hypothesized that a non-invasive deep phenotyping of individuals with or without alcohol use disorder across multiple cognitive, psychological, and behavioral domains would detect latent domains mediating vulnerability and progression to addiction. And what we came up with, what factored out in a massive factor analysis, and even in a split population design, were negative emotionality, executive function, and incentive salience. So in a sense, I feel that these were collected in 454 patients at the clinical center from 2015 and 2016. So we're not forcing anybody to do this kind of work at NIAAA, but we're encouraging others to look into this issue. We are currently running a protocol at the clinical center to follow up on these initial data. But I think it does argue that a lot of what we learned from the basic circuitry that Josh was talking about has now been extended and actually validated in a human condition. So what are some of the big issues for the Alcohol Institute that we face in 2020? Well, alcohol and women's health, for one. Gaps between women and men are narrowing for prevalence, early onset drinking, frequency and intensity of drinking, having an alcohol use disorder, drunk driving, and self-reported consequences. I'll show you one piece of data in a second, but I want to explain to you, in college drinking now, women are drinking as much as men. And that is completely new. That's a complete flip of the way it's been for about 50 years. Women more likely to experience and here's the bad news, women are more likely to experience blackouts, liver inflammation, brain atrophy, cognitive deficits, certain cancers, negative affect during withdrawal and stress, and anxiety-induced relapse. And we have been doing studies on women, particularly in the clinical domain, but only 26% of 230 structural neuroimaging studies on substance use over 23 years actually evaluated sex differences. So we need more research to better understand sex differences in alcohol use and its consequences. We're supporting a lot of that research. Much of our preclinical work now requires that females are included. But I'm just saying there's a lot of work to be done in this domain, and it's very important for the alcohol field. For those of you in my generation, there's rising alcohol use among older adults. From 2002 to 2018, past month, alcohol use increased for men and women aged 65 and older, but you'll also see, if you can see it at the back, for women, they're closing in on men as the percentage of use. And 1 in 10 older adults in the United States engage in binge drinking. I don't know, I find it hard to believe that people in my generation are binge drinking, but apparently they are. Alcohol misuse among this population contributes to accelerated aging in some brain regions, including the frontal cortex, pronounced reductions in brain volume in multiple cortical regions, impaired cognitive function, learning, memory, and motor function. We're supporting research in this area with an RFA. And we're particularly happy with our collaboration with the Aging Institute. They've been, for the past several years, supplementing our grants to pursue questions in this aging domain. So this is another exciting area for future work. I want to remind you, I said this last year, that and to reiterate again what some of the previous directors said, that sleep is an important endophenotype of alcohol use disorder and substance use disorder. This is also a narcissistic slide because I'm highlighting the fact I'm giving a talk on this for the Neuropsychopharmacology Reviews plenary tomorrow. But I think you will see that alcohol disrupts sleep, and alcohol use disorders have pronounced effects in producing a sleep dysfunction, and we also believe that sleep dysfunction contributes to the onset and maintenance of alcohol use disorders, and of course, relapse. So it's a really interesting area and it's had old attention, as you'll see tomorrow from my talk, but I think it needs some new attention. And then we are, one of the problems with treating addiction is that it's not detoxification. And in the alcohol field, this is particularly important. Going to a 28-day facility is absolutely necessary for some very severe cases of alcohol use disorder, but it's not sufficient for treatment. And what we really need is is treatment post-detoxification. We've been struggling at the Institute to come up a word for that, and we've decided for the moment we're just going to call it transitions. But one of the things we're interested in doing is closing this treatment gap. In the US, fewer than 10% of people with alcohol use disorder receive any form of treatment, and I believe that's similar for other substance use disorders. Routine healthcare presents a unique opportunity for prevention, early intervention, and treatment of alcohol use disorder. However, many health providers do not perform alcohol screening, are not aware of evidence-based treatments, do not know where to refer patients for treatment. Our goals are to improve physician training in substance abuse prevention and treatment at all levels, and integrate prevention, early intervention, treatment, and follow-up into routine health care. So one of the things we've been doing is providing resources for clinicians. We've updated the Alcohol Treatment Navigator. This is a new portal to help healthcare professionals build or expand their referral lists to include providers offering up-to-date, science-backed alcohol use disorder treatments that meet the varied needs of their patients. There's a website you can look at the Treatment Navigator, and what we have in development is what we're calling a clinician's core resource. And this is basically everything a clinician, and I mean everybody from a clinical psychologist to a nurse practitioner to a pharmacist to an addiction psychiatrist, and a primary care doc, what they should know about alcohol. And I hate to tell you, after 6 years of doing this job, they don't know very much about alcohol. And so we're going to have in this presentation how alcohol problems present in primary care, role in common co-occurring morbidity and conditions, all the way down to interactions with commonly used medications, which I've already alluded to. I'm not going to go through the list. This is under production. We hope that many organizations, including ACNP, will help us vet this and throw tomatoes if necessary, but we look forward to your help. And then finally, I'm going to come out very strongly on another point. We've been changing our website. We've been changing our publications to reflect this. Actually includes a discussion I had with Bob DuPont, who was a former director of NIDA and very active in this area. But I just want to remind you about the US dietary guidelines for alcohol consumptions. For adults 21 and over, no more than 2 drinks per day for men, and no more than 1 drink per day for women. Now, these dietary guidelines are reflecting the fact that just about, in fact, when it comes to cancer, there is no safe amount of alcohol. And so, yes, we all drink socially, or many of us. Yes, alcohol is a social lubricant. But, you know, I think at some point we have to recognize that there are some people who shouldn't drink, some people who may not want to drink, and there should be alternatives to drinking. And I remind the ACNP of that as well. For individuals under 21, no alcohol is allowed. Basically, it's against the law for purchasing or publicly possessing alcoholic beverages under 21. And I might add, there's a straight line decrease in underage drinking in this country, a straight line decrease in drunk driving, some of which is attributable to this law. And then others who should avoid alcohol completely include those who plan to drive or operate heavy machinery or participate in activities that require skill, coordination, and alertness, have certain medical conditions or take certain medications. We're back to that interaction. Are recovering from alcohol use disorder, unable to control the amount that they drink, are pregnant or trying to get pregnant. And finally, alcohol and mental health is the elephant in the room. And I loop back to Paul Summergaard's comment. Alcohol misuse correlates with poor mental health, often precedes diagnoses of mental health conditions. It's commonly used in an effort to cope with symptoms. In the end, it makes the prognosis worse. Similarly, mental health conditions complicate the treatment for alcohol use disorder. And if you can't read this cartoon, it says, I'm right here in the room and no one even acknowledges me. So I want to thank you very much. These are our publications, and I'm not sure who's next, but.